So today it will be we will talk about USMLE Step 2 CK Hematology. It will be part 7, and we will discuss about the clonal myeloproliferative disease (CMD) and macrocytic anemia. General discussion. So it will be not very big lecture, and before we go on there, we have to know that the patient come and we do the CBC. He could be normal, or he is complaining that he has a fatigue, and we do the CBC and we found his red blood cell hematocrit value is high, greater than 50%, and in this case we have to know what is exactly causing his red blood cell is high. So we talk about the Polycythemia vera. What is the Polycythemia vera? When bone marrow increase production of the red blood cell. This is kind of neoplasm, and so bone marrow itself is start producing uncontrollable red blood cell, and we call it Polycythemia vera. We also call it clonal myeloproliferative disease. So in this case, when we do the CBC, we found red blood cell increase, white blood cell increase, and platelet increase, and we do after that the erythropoietin, and we found erythropoietin is low. So red blood cell increase. After that, we have to do the test for erythropoietin is increase or decrease. If it is decrease, we will be say Polycythemia vera, and is caused by clonal myeloproliferative disease. And if it be decrease, then we find out he has Polycythemia vera or clonal myeloproliferative disease. His bone marrow is causing overproduction of the red blood cell without the stimulation of the erythropoietin. So when erythropoietin is high, and we can think the person has high red blood cell due to hypoxia. What can cause hypoxia? If he has a lung disease, if he have a heart disease, and if he live in an environment where has low oxygen, like say in high altitude, and automobile exertion, which is the source of the carbon monoxide. So if you have a carbon monoxide poisoning, he could develop hypoxia, and carboxyl, they say carbon monoxide poisoning can cause carboxyhemoglobinemia. So he has a hypoxia that can stimulate the kidney to produce erythropoietin, and thus erythropoietin stimulate the bone marrow, and bone marrow will constantly start producing the red blood cell that cause the increased production of the red blood cell. Also, we talk about the AV shunt, like the blood is going from the right side to left side without going to the lung, and that can cause the hypoxia. Sleep apnea is increased pulmonary hypertension, they can cause hypoxia. And if this person doesn't have all this problem, no hypoxia, and you do the ABG, his oxygen saturation, everything is normal, no carboxyl hemoglobinemia, and after that you have to do. So ABC is very important on here to know the hypoxia. So after erythropoietin is high, do the ABG, and after that if AG is normal and his erythropoietin is high, so you can think probably this person has kind of cancer like neoplasm probably going on. Like say adult polycystic kidney disease can increase production of erythropoietin. Renal cell carcinoma can increase production of erythropoietin. Hepatocellular carcinoma, adrenal adenoma, anything also increase the cortisol, that can increase the erythropoietin, and increase erythropoietin can increase production of the red blood cell. And so we have to find out the three things: bone marrow overstimulated by cell, erythropoietin is low, hypoxia, increased production of the erythropoietin, and the kidney disease or other disease can increase production of the erythropoietin or increase production of the cortisol, that increase production of the erythropoietin, then we can have high amount of red blood cell. And also differentiate between the bone marrow is the clonal myeloproliferative disease. In red blood cell, white blood cell fertility will increase. In hypoxia and other cause like say polycystic kidney disease with erythropoietin increase only, so it give only increase the red blood cell. White blood cell and fertility will be in normal range. So let's talk about the clonal myeloproliferative disease. This is a Polycythemia vera. So what is Polycythemia vera? Polycythemia vera is a chronic clonal blood cancer, and is chronic blood cancer is a chronic disease, is not acute, which produce too many red blood cell, white blood cell platelet. Polycythemia vera is part of the group of disease called myeloproliferative neoplasm. And Polycythemia vera patient have most of the case no problem, they don't complain any health. And usually when we do the routine health maintenance visit and we do the CBC, we can find his high red blood cell high, or when hematocrit value is go very high sometime, and they can complain they have fatigue. Polycythemia vera is the unknown cause of clonal myeloproliferative disease. We don't know why this is happened, no etiology. And this is a kind of pluripotent hematopoietic stem cell. Pluripotent hematopoietic stem cell that's overstimulated suddenly or lose the control and start producing a lot of red blood cell. And when someone have Polycythemia vera and like by clonal myeloproliferative disease, this patient in the future can develop acute myelogenous leukemia, AML. Polycythemia vera, all kind of cell will be increased. So basophil will be increased. We already know that when basophil will increase, serum histamine will increase, and this histamine will go to the parietal cell in the stomach, and it can cause the peptic ulcer disease by producing a lot of H plus hydrogen. And we also know that the histamine called the isin. So polycythemia vera due to clonal myeloproliferative disease, we can found this patient could have peptic ulcer disease, also easing. So basophil increase in all myeloproliferative disease. So this patient can, when myeloproliferative disease going on, basophil will increase, and this patient would have peptic ulcer disease, and same time he could have easing. So red blood cell will increase, it can give the sludging. Too much red blood cell, it can cause the viscosity. And when it happens, it can injure the red blood, the blood vessel. When this sludging or viscosity cause hyperviscosity of the blood vessel, it can injure the blood vessel, and patient can complain headache, dizziness, paresthesia, blurred vision. So hyperviscosity when injure the blood vessel, it can cause the thrombosis at the blood vessel, and when it will be blood vessel will be injured, clot will be formed. When too much clot will be formed, the factor will be tuned up, then it can cause the bleeding problem. So increased platelet count and impaired platelet function, which happen in the clonal myeloproliferative disease, patient could have thrombosis, he have a clotting problem, same time he has hemorrhagic phenomena, because he is developing clot, and a lot of clot the factor is using on there, and same time he is burning clot, and same time he will develop the bleeding problem. And when too much red blood cell in the system, when it will be breaking down, like say red blood cell, white blood cell, all will break down, it can cause increase the uric acid, and uric acid increase the gouty arthritis, and when uric acid increase, it can cause the crystal at the kidney, and it can injure the kidney, and it can cause the creatinine can increase, the creatinine can increase, and patient could have kidney failure too. And what we will see in physical exam in clonal myeloproliferative disease, now we are talking about polycythemia vera, which is a pluripotent hematopoietic stem cell disorder. And this case, all kind of cell will increase, erythropoietin will be low, red blood cell is high, erythropoietin will go down, normal physiological response. He has too much cells and in the system, and so all red blood cell, platelet, white blood cell, it will also go to the spleen, then it can give the spleen big, so patient could have splenomegaly. And he have engrossment of the blood vessel, and you will see also his face will be pink, and due to plethora, so his body probably will be little pinkish looking. So we already discussed about when too much blood cell, it can have sludging, it can have viscosity of the blood vessel increase, and it can injure the blood vessel. He has a clotting problem, and he has like say thrombosis, and same time he has bleeding problem will going on because he chew up a lot of clotting factor. When we do the diagnosis, the physical exam, this patient could have high blood pressure. So when someone have high blood pressure, and person is a little old people, usually these people are old people most of the case. So when blood pressure is high, do the CBC to know the hematocrit value. So we already talking about the high reticulocyte. His hematocrit value is high, and he can have hyperviscosity in his blood vessel. So that can cause his hypertension, and he can has thrombosis and splenomegaly. This is the definition of the polycythemia vera. Polycythemia vera happen very important stem cell disorder, which is called the clonal myeloproliferative disease. This is a kind of neoplasm. So what we will find in the lab? In the lab, we will see the CBC, and we found red blood cell, white blood cell platelet will be increased significantly. It can be even greater than 60%. Hemoglobin, hematocrit will be high. Mean corpuscular volume could be normal. So this guy is producing too much red blood cell. He is using a lot of resource for it. So if we use the if you don't use that, if we go like this, it can have depletion of the iron after some point. So first, initially, even if we have normal red blood cell, size of the red blood cell is normal, mid corpuscular volume is 80 to 100. After some time, when he will develop the iron deficiency anemia, and his red blood cell will be microcytic hypochromic anemia. Mean corpuscular hemoglobin could be normal, depend on the situation, and mid corpuscular hemoglobin concentration could be normal. So this patient have in the future, this patient, if it be iron will be not replaced, he can develop iron deficiency anemia. And this patient also have risks to develop acute myelogenous leukemia. And we already talked about the erythropoietin will be decreased, and if we do the ABG, and his ABG will be normal range. This is one of the important tests on here, particularly when erythropoietin is high. Then ABG will differentiate is hypoxia, or any system is producing, like say cancer is producing the erythropoietin, or cancer is producing too much, or any system like say adenoma, or like say adrenal adenoma is producing too much cortisol, that is producing too much erythropoietin, and that can cause the person to have high increase of the red blood cell. In this case, ABG will important to differentiate is the hypoxia is the cause, or the cancer is causing the to have high level of erythropoietin, that ultimately give the high level of red blood cell. So BUN and creatinine probably will be normal, but and BUN, when uric acid will injure the kidney, BUN and creatinine could increase. Like say after red blood cell will be breakdown, white blood cell will be breakdown, it will produce the uric acid. Person could have gout, and person could develop urate crystal, and in the kidney, when it will be passed through the kidney, it will damage the kidney, and kidney failure would happen over time. And so for this patient, very important to treat the gout, to keep his uric acid level in normal range. Otherwise, he can have kidney failure, he can have gout, so his joint problem will be happen, So erythrocyte sedimentation rate could be low. Only we know that when inflammation going on, erythrocyte sedimentation will be high. Erythrocyte sedimentation low to normal. So if this person has, like say, multiple myeloma, and he has a lot of antibody in the system, and other autoimmune disease, all this case it can increase the erythrocyte redimentation rate. We already discussed what is erythrocyte redimentation rate. When inflammation is going on, or this kind of thing make the red blood cell heavy, and so erythrocyte redimentation rate will be increased. This person already talking about he could develop the iron deficiency anemia because he's producing too much red blood cell in a small amount of time. So most accurate test to find the chronic myelogenous deficiency, chronic myeloproliferative disease, is the JAK2 mutation. Clonal myeloproliferative disease at the mutation. So total blood volume will increase. That can cause the plethora, which is responsible to increase the blood pressure. If we do the bone marrow biopsy, it will be hypercellular because pluripotent stem cell disorder, and too much red blood cell is producing on there, and leukocyte alkaline phosphatase will be increased. Leukocyte alkaline phosphatase also increase in leukomoid reaction, and leukocyte alkaline phosphate decrease in chronic myelogenous leukemia. Chronic myelogenous leukemia, leukocyte alkaline phosphatase will be decreased. So when leukocyte alkaline phosphatase will be increased in 4 cases: leukomoid reaction, myelofibrosis, polycythemia vera, essential thrombocytosis. Leukocyte alkaline phosphatase will decrease in chronic myelogenous leukemia, aplastic anemia, pernicious anemia. So what we can do to a patient who has polycythemia vera, due to clonal myeloproliferative disease, he has too much red blood cell in his system, so we will do the phlebotomy. We will just take some blood out from his system, and we can also give hydroxyurea which will suppress the bone marrow, and bone marrow will produce less amount of red blood cell. What if someone has polycythemia vera, chronic myeloproliferative disorder? In the future, he can develop bone marrow fibrosis. If bone marrow fibrosis develop, he can have aplastic anemia. Then, to produce too much red blood cell, to come to a decreasing to produce the red blood cell, and this person is in risk to produce acute myelogenous leukemia. So we should make a note that all polycythemia vera patient has same symptom, physical exam, diagnosis, and treatment. Only difference is that low serum and urine erythropoietin in clonal myeloproliferative disease, and high serum and urine erythropoietin in other. I'm saying high red blood cell. When red blood cell will be increased, the red blood cell, when all red blood cell will increase, is physical exam, diagnosis, and treatment all will be same. The only difference is the erythropoietin. On here, erythropoietin will be high in polycythemia vera due to chronic myeloproliferative disorder. Erythropoietin will be low on polycythemia vera. In chronic myeloproliferative disorder, erythropoietin will be high in hypoxia or other cancer which increase the erythropoietin, or cortisol based steroid. So what will be the differential diagnosis for polycythemia vera? Myelogenous leukemia. So this is the end of this lecture. I hope you all, I am giving the lecture for a student to know everything what they need to do well in the USMLE exam, and this lecture will help the medical student who is doing the rotation. And in the future I will put all my lecture in the website, so anytime student have time, they have time, and like say they are in the cafeteria or other place, they're at home and they can listen the lecture. And if any student will know all this material after listening the lecture, just try to think and to question yourself, do you know all this material? If you know all this material, you will, I hope you will definitely will do very well in the USMLE exam. So this will be our part 7. Next time I will I will also, here I will include the microcytic anemia. And what is the microcytic anemia? We already know that person came to your office, he look pale, and you do the blood test and his hemoglobin hematocrit is low. You thinking he has anemia, and next step you do his mid-corpuscular volume and reticulocyte, and you found his mid-corpuscular volume is over 100, his reticulocyte is low, and now you are thinking he has macrocytic anemia. What is the next step you will do? You do the peripheral blood smear and you are looking for hyperpigmented neutrophil. If hyperpigmented neutrophil is on there, then we will call that is person has megaloblastic macrocytic anemia. What can cause it? Vitamin B12 deficiency or folic acid deficiency can cause megaloblastic macrocytic anemia. The deficiency of vitamin B12 and folic acid both can cause decreased DNA synthesis, decreased synthesis of the furin, result in decreased red blood cell production, and there will be faulty red blood cell will be produced in the bone marrow, and this red blood cell will be destroyed at the bone marrow. So person could have macrocytic anemia, and he will have megaloblastic macrocytic anemia when patient has deficiency of vitamin B12 and folic acid. And talk a little bit about vitamin B12. We know that the stomach producing the intrinsic factor that help the vitamin B12 to absorb at the terminal ileum. And again, when patient has vitamin B12 and folic acid deficiency, patient can develop megaloblastic anemia, where in blood smear we will see hyperpigmented neutrophil. So after found that his hemoglobin hematocrit is low, do the mean corpuscular volume and reticulocyte count, both come will low. Next step, you do the peripheral smear to know that to find any hyperpigmented neutrophil or not. If hyperpigmented neutrophil, you will come to the conclusion he has a vitamin B12 deficiency, folic acid deficiency, then you can do the blood test to find out these two deficiencies. If it's not, something else is causing the macrocytic anemia. So what is the other thing can cause macrocytic anemia? Myelodysplastic syndrome, patient is in phenytoin, gidobodine, like say is in drugs. Sideroblastic anemia can cause it, alcohol can cause it, liver disease, hydroxyurea all can cause and give the macrocytic anemia. And if we do the biopsy of the bone marrow, and we will find the large abnormal looking erythroid precursor cell in all kind of macrocytic leukemia. So we already talked about his reticulocyte production will be low, and when this person produce all kind of abnormal cell, macrocyte cell, his red blood cell will be destroyed in the bone marrow while they will live when they will try to leave the bone marrow. Bone marrow will already destroy a lot of themselves of this red blood cell, so his reticulocyte will be low. So again, after know the CBC and mean corpuscular volume, and you found the patient has microcytic anemia, reticulocyte is low, do the peripheral blood smear and look for hypersegmented neutrophil, which will be fine. You will find the hypersegmented neutrophil when patient has deficiency of the vitamin B12 and folic acid. And if there is no hypersegmented neutrophil, there is something else is causing the person to have macrocytic anemia, like myelodysplastic syndrome, phenytoin, ditobodine, sideroblast anemia, alcohol, liver disease, hydroxyurea. So when you find the hypersegmented neutrophil, you are come to the conclusion that the person has megaloblastic microcytic anemia, which is caused by the vitamin B12 and folic acid deficiency. Then you do the blood test and you will come to the conclusion which one is causing the problem. So this is it for today, and next time I will talk about USMLE step 2 CK part 8, and it will be about vitamin B12 deficiency and probably folic acid deficiency, because I don't want to make a lecture more than an hour, but vitamin B12 deficiency it will be a big lecture. So thank you for your time. Thank you to listen.